This is Kristen Elliott. We'll be reviewing lifespan considerations for nursing pharmacology. Chapter 3. In terms of lifespan considerations, we typically talk about drugs in relation to adult bodies. Now, the pharmacokinetics differ in women who are pregnant or breastfeeding, neonates and pediatrics, as well as elderly. The human body changes throughout the lifespan. This is going to change how we medicate. For women who are pregnant, we're concerned about the drug reaching the fetal circulation. The fetus is exposed to many substances that mom is exposed to. Teratogens, which is an important term to know, is a substance that crosses the placenta and causes birth defects. We have FDA categories that you can see in your book. The FDA categories talk about how safe it is to take a medication during pregnancy. These categories range from A to D, including X. Recently, the FDA advised against using these categories and said it was safer to describe what happens when a mother takes the drug and how it can affect the fetus than labeling categories, but we'll still see categories. So category A is no risk to human. So there's been studies looking at the effect of the drug on the human fetus, and they have found no risk. Not a lot of drugs are characterized as A. Category B means that there's been studies done on animals, and there's been shown to be no risk to the animal fetus. C, there's an adverse effect to the animal fetus, and we have no information about humans. D, there is possible harm, but it's a risk versus benefit decision. If that medication is really necessary for mom, we may give the medication. And X means that there have been fetal abnormalities reported. This is a drug we're probably never going to use. So for the fetus to get the drug into their circulation, it has to go across the placenta. So between the baby and mom, there's just a cell membrane that separates the blood. So as we can see here, we have the fetal circulation, and down at the bottom, when it gets to that purple area, that's when it goes into the fetal circulation. Here, I just want to impress on you how thin that membrane is between the maternal blood and fetal blood. It's really just a few cells. So it's easy for those drugs to get across from the maternal blood into the fetal bloodstream. Now, the impacts on the fetus vary by the trimester. So as we can see over here, we start in the blue area with 1 or 2 cells, right? So it's a very small amount of cells that end up going to the pink area. So this little cell turns into this fetus. In the first trimester, this is the period of greatest danger. We can see this huge cellular transformation. And this is where organogenesis occurs. This is the development of organs of the fetus. So if this medication is harmful, it can cause abnormality in that development. The third trimester, which starts at this third arrow, the fetus is bigger here. So the greatest percentage of maternally absorbed drugs gets to the fetus. The fetus has so much blood flow that if the drug is in the maternal bloodstream, a lot more of it is going to get to the fetus. Now, breastfeeding, we talked about excretion. What's the main organ for excretion? Kidneys. So that's the majority of excretion, but some drugs can be excreted in breast milk. Now, the concentration is typically lower. Sometimes it does not matter, but sometimes it does. Sometimes a significant amount occurs. A lot of times when we're talking about antidepressants, we can see this. It just matters, how is that drug going to affect the baby? Some drugs that are excreted can cause the baby to be really sleepy. This is going to be concerning. Some of them have shown no adverse effect, and those drugs are okay to take during breastfeeding. Now, for our pediatric patients or our neonates, our medication is going to be weight-based. So let's see. So it's important to know because we're going to do this in kilograms. So 1 kilogram equals 2.2 pounds. So this is important because the medications almost exclusively are going to be in kilograms. We'll talk about errors later. There have been errors that occur because we're basing that weight on pounds instead of kilograms. And as you can see, that's 2.2 times more. So we need to be very cautious about this. If you think about it, if I'm giving you ibuprofen, I'm going to give you 400 to 800, somewhere within there. Really kind of regardless to how much you weigh as an adult patient. With kids, it's all going to be weight-based. So a 2-year-old cannot get the same amount of medication as an 8-year-old. So this is a huge area of safety. Some other things that we see, their skin is going to be thin and permeable. So if we put a topical medication on there, it can absorb a lot quicker. Gastric pH is less acidic when we're talking about oral medications. That can alter absorption. Gastric emptying is slowed. That means a lot more of the medication is going to stay in the gut instead of moving through. The liver and kidneys are immature. We know the liver is responsible for metabolism, and the kidneys are responsible for excretion. We may get buildup of those drugs if we can't do either appropriately. Now, changes in the elderly. So let's think about it. You've got this 85-year-old lady. She's lovely. She has congestive heart failure. She's had 2 heart attacks and chronic angina. She has diabetes. She has depression. And she's developing Alzheimer's. So as we can see, it would be very easy for this patient to have 8 or 9 medications on a med list. Older patients are going to have a lot more conditions that need to be treated with medication than younger patients. So polypharmacy is one of your vocabulary words. That's just a lot of medications. So you need to use a lot of caution with these patients. So not only are they on a lot of medication, they have some changes to pharmacokinetics. So they have a decreased cardiac output, which is going to decrease absorption and distribution. They have a reduced liver size and decreased blood flow. That's going to reduce metabolism. And then they're going to have a reduced glomerular filtration rate, which is how fast we're moving stuff through the kidneys, and decreased blood flow, which is going to change their excretion. And their GI system, which we know most of those medications are going to be taken orally, their gastric pH may be less acidic, which can alter their absorption. They have slowed gastric emptying, which means the drugs are going to stay in their gut a lot longer. They could have a reduced blood flow to the GI tract. We know that the absorption and distribution is dependent on the blood flow. And they have reduced absorptive surfaces due to flattened intestinal villi. We saw in the video, those villi have a larger surface area. If we have flattened intestinal villi, we're not going to absorb as much of the medication. Now, I just wanted to point out, when we're thinking about older adults, we can think about the Beers criteria. So the Beers criteria is a list of potentially inappropriate medications in older adults, and we will want to avoid these drugs if at all possible.